ability to do this symposium and to provide you with the relevant information. I'm very much pleased to do this session together with two eminent, very eminent speakers. Professor Amos Korczyn from the Tel Aviv University, Israel, and Professor Antonio Federico from Siena, Italy. Really, they don't need any introduction, but I will do it before each talk. And we will discuss one of the most important, one of the hottest topics in the current neurology, in the modern neurology. We will discuss the possibility to prevent or to ameliorate the post-stroke cognitive decline. And please take your seats. And it's my great pleasure to ask to the podium Professor Amos Korczyn from Israel Tel Aviv University. Once again, Professor Korczyn does not need any introduction. He is the chairman, the honored chairman of the Department of Neurology of the Tel Aviv Medical Center. He is organizing the most important and the well-attended congresses in neurology, like controversies of neurology, brain and mind, and some other congresses. He is the author of more than 600 PubMed-recorded papers. So that's Amos Korczyn. We all know him, and we're very much pleased to listen to his talk that is dedicated to the problems and current status of post-stroke cognitive impairment. Amos, you are very welcome.
We should change the presentation of...
Can we have the first slide, please?
I've got it. Okay.
So, good evening, everybody. Thank you very much, Professor Korczyn, for the very nice introduction. It's a pleasure to be here in Berlin again, and particularly at this Takeda Symposium. It is a pleasure to be invited to talk to you and to tell you what I see as the important issue, and I will hopefully be able to convince you that it's an important issue of the cognitive impairment that follows stroke. So PSCI stands for post-stroke cognitive impairment. Well, as you know, many of you are aware that 1/3 of us will develop stroke or dementia or both. So anybody who's sitting there should think, is it himself or herself, or the one sitting on the right or on their left, who will develop cognitive impairment or stroke. You cannot make up this important decision now, but be careful, because this is an important issue. Now, of course, dementia is not only something that happens after a stroke. There are several causes, and you know them: Alzheimer's disease, frontotemporal dementia, Lewy body dementia, and what we are going to discuss now is the context of vascular dementias. And so what are vascular cognitive impairment? This is a general term. It's a group of disorders, not a single entity, but rather a group of disorders consisting of cognitive impairment, presumably which we think are due to either cerebral ischemia in most cases or hemorrhage in some cases. And it's important to know that this is a group of disorders because the cases do not necessarily share common etiology, common mechanism, or common evolution. The mechanism, of course, can be either hemorrhage or thrombosis, vasospasm, low perfusion, rarely also hematological or neurological causes. Different mechanisms underlie this. Of course, we speak about different syndromes. So we speak about multi-infarct dementia, or if it's cortical mainly, lacunar states, if it's in white matter, single strategically placed infarct, maybe in the left thalamus, is likely to cause cognitive impairment as well. Binswanger's disease, the primary affection of the white matter. Genetic forms like CADASIL, you'll hear much more about it from the next speaker. Genetic forms other than CADASIL can also contribute. Hypoxic ischemic encephalopathy and post-stroke cognitive impairment, which I would like to discuss with you today. As I said, it's a complex neurological issue, and I have tried to delineate and go into details of this in a paper written a while back, but actually nothing dramatic has changed since then. What is the epidemiology of vascular cognitive impairment? We think that it's about the second most common cause of dementia, but actually we don't know. We don't know the details, and the reasons that we don't know are important to realize. Firstly, is because there is poor definition of the disorder of vascular cognitive impairment, particularly how to differentiate the vascular causes from the primary degenerative diseases that very much look like vascular cognitive impairment in many cases. So Alzheimer's disease and frontotemporal dementia can mimic vascular cognitive impairment. Vascular cognitive impairment can mimic AD or frontotemporal dementia, and it's not clear to assign Don't go from one extreme to the other. I want to tell you that the electricity went on, but the clock kept moving, so I hope I didn't lose too much time. So as I was saying, it's difficult to assign a certain diagnosis to each patient, and therefore it is not clear what are the actual epidemiological data. Now, is stroke related to dementia? Obviously, yes. So, in a study that we've done several years ago, Reves, Professor Korczyn, and myself, and others, we looked at patients who were released, discharged from our hospital in Tel Aviv, and we only took patients who were discharged without cognitive impairment, and we followed them up. And as you can see, when we examined them 3 months later, we saw that several of them, 8%, 8.5% to be exact, became demented. And this figure grew over the next 3 years of follow-up to reach about 1/3. So 1/3 of these patients who were discharged again without cognitive impairment following their first ever stroke developed cognitive impairment later on. So two things are important to realize here. First, that not all of them developed. And secondly, that there was a time difference between the occurrence of the stroke and the development of dementia. Now, these are two things that I want to stress here. The question, not all of them develop dementia, then the question is, who is at risk? Because these are the people that we have to target in trying to prevent the cognitive decline. And then the importance of a time window. So because they don't develop the cognitive impairment right away, but rather several months or a couple of years later, this means that we have a time window in which we can intervene if only we could know how to do it. So this important paper which was written just recently, a consensus paper, Postural Cognitive Decline, and this is an update and perspective for clinical research, written jointly by Michael Greiner as the first author, and of course our chairperson, Alagiach, as one of the other participants here. And the question that they wanted to answer is, who can develop postural cognitive impairment and what can be offered? So, as I mentioned before, there is a therapy window. The predictors that they have identified are imaging markers. There are also biomarkers that we want to have to talk about, and they stress the issue that so far, as you all know, there is no drug that has proven efficacy in this situation. What are the predictors? So one of them, an important one, is MOCA. This is a neuropsychological test. You are all aware of it, or maybe if you are aware with the mini-mental, this is quite similar, although it is better because it includes several more data on executive functions. Still, it's the same length of time that it takes, maybe 5 minutes to perform this, or 10 minutes, depending on the patient and the examiner. And this is much better than the mini-mental state examination in evaluating the current situation of the patient at that time. And if they have done it, and we did the same in a patient right after the stroke, this can predict who will develop dementia later on. So this is an important contribution, that we now know how to identify patients who are at higher risk. Now, of course, you all know that there are these risk factors for dementia in stroke survivors, and they're the same risk factors that apply in the general population. So there are these stroke-related factors, those that actually contributed to the occurrence of the stroke, like if there was a hemorrhage or not, if the lesions were on the left or on the right, if they were large or small, if they were only on one side or bilateral, if there were more than one stroke, if it was a large middle cerebral artery infarction, of course the chances of developing cognitive impairment is more than if it was a cerebellar lesion or a posterior occipital lesion. And of course, frontal lobe damage is also an important thing, and as I mentioned before, if there are multiple strokes, so all these risk factors for dementia, and actually these are the risk factors for dementia, even in patients, or several of them are risk factors for dementia anyway. Why does it go the other way? Now, we know that there are these risk factors for dementia in general. So in the general population, whether they are going to develop stroke or dementia of the degenerative type, hypertension, atherosclerosis, coronary artery disease, smoking, hyperhomocystinemia, diabetes and apolipoprotein E SPL4 status, high dietary saturated fats, midlife cholesterol, all these are risk factors. So those of you here in the audience who carry any of them are at a higher risk of developing dementia anyway. And stroke, both dementia, degenerative dementia and stroke. Neglected risk factors, which I think are important, are depression, anxiety and stress, obstructive sleep apnea, and hypotension. So these are, but if we go back to this raises an important question. How can it be that the same risk factors are responsible for primary degenerative diseases like Alzheimer's disease, and for stroke, and for, of course, coronary artery disease, and so on. So, what is it? This was a surprise that came out of the epidemiological studies that were done. The commonality of this risk factor for all these things, and also for post-stroke cognitive impairment. And the answer, or part of the answer at least, came from the so-called NANS study. This was a large study that was done in America and still being continued on nuns who were ordered by the sister who was in charge that they should undergo cognitive testing or neurological testing annually by neurologists. And this neurological assessment includes also cognitive assessment. And after their death, they were ordered also to contribute their brains for research. This was very important because what was found is that when these older nuns died, several of them had a load of amyloid and neurofibrillary tangles in their brain. This is not surprising. We know that this is something that occurs with age. But what was surprising is that not all of them who had this load, who fulfilled criteria for Alzheimer's disease, not all of them were demented. About half of them were demented. So the question was, what is it that causes one of them to develop dementia and the others not if they have both Alzheimer's disease? So the first question, the assumption was that it was more amyloid or more neurofibrillary tangles, but the answer is no, they had equal amounts. And yet some of them developed dementia and some not. It turned out that those who developed dementia were much more likely to have an additional lesion, which is vascular lesion. And these were very frequently small lacunes in the basal ganglia that the neurologists who have examined them have not suspected in life. These were very small, and they were not by themselves, they were not enough to do anything. But on the background of Alzheimer's pathology, they were enough to tilt the balance and cause cognitive impairment. These were what we call in the Middle East the stroke, the small things that can break the camel's back. So, therefore, I think that we should consider that in older people, all dementia is actually mixed dementia. There is no such thing as pure Alzheimer's disease, or almost no such thing as pure Alzheimer's disease. Well, maybe people who carry mutations in presenilin gene or in APP gene, they develop dementia at a younger age. They do not develop yet the vascular changes, so they are more clean. Patients with CADASIL that Professor Federico will tell us about later on the other side of the extreme. They have pure vascular lesions and very little, if any, Alzheimer's lesions. But most of the elderly people, so these are young people, most of the elderly people who develop dementia, by the age they develop dementia, they have already accumulated both Alzheimer's pathology and vascular pathology. So all dementia is mixed dementia. This is something, again, that I wrote several years ago, and new data support it more and more. When I wrote it first, it was not well accepted, but now I think most people who work in the field will agree that most dementia in elderly are due to mixed causes, not only amyloid, but also vascular lesions and additional. So this issue of the multi-causality of dementia in stroke survivors leads to important conclusions, because we can assume, therefore, that no single intervention will be sufficient to prevent or cure the disorder. And maybe, therefore, we need multifunctional interventions in those patients. Of course, prevention is the best therapy, and we've already mentioned the risk factors which are important. So prevention is the best therapy. So those of you who still smoke should stop it right away. Those of you who do not know what the blood pressure is, they should measure it, as well as the cholesterol level. Lifestyle changes are very important, and you know them, so we don't go into details. Now, what can we do? So, of course, when we see patients who had undergone a stroke and now are developing cognitive decline, what can we do? We give them the same drugs that we give Alzheimer's disease, and this has been done with donepezil, and this is our study with galantamine, which showed some effects, small effects, but really even the effect of cholesterol inhibitor in Alzheimer's disease is not that big. But here it's half as big. So it's a very minor effect, does not reach the minimum threshold that the FDA would demand in order to register the drug. So this is no help in these cases. So what does the future hold in these terms? How can we protect the ischemic stroke? This will come up in the talk by Professor Korczyn. But in conclusion, I want to say that dementia is the expression of cumulative brain tissue damage. Cases of pure AD or pure vascular disease constitute the extreme and rare ends of a continuum, and several pathological processes act in parallel to reach the threshold that causes dementia. Post-stroke cognitive impairment is a very important problem, but mixed and complex, and specific and smart therapy strategy is needed to be developed. And the Takeda results that you will hear about are maybe the way to define therapeutic strategies. We are all looking forward to see more results from studies such as that. Stroke and dementia are highly prevalent, but without easy and highly effective solutions in the foreseeable future. Post-stroke cognitive impairment is an important problem, but mixed and complex. With this I will end. Before I will tell you about the Vascular Dementia Congress. I told you that vascular dementia does not exist, but a meeting on vascular dementia does exist, and you are all welcome to come to beautiful Ljubljana in October to attend our Congress. There are flyers outside, and those who are busy on those days are invited to come to CONI, the 10th World Congress on Controversies in Neurology, to hear in Lisbon, March 2016. Beautiful place, excellent program. And with this I will end. Thank you very much for your attention.
Thank you very much for the fascinating talk. Dear colleagues, we discussed that probably it would be more comfortable for the audience to write questions on the cards, and then at the end of